We previously discussed how NSAIDs help us in relieving pain, inflammation, and fever. Now, we'll talk about how these NSAIDs can have negative consequences on our body. Adverse effects of NSAIDs are common, partly because the drugs may be given in high doses for a long time and partly because they are widely used in elderly patients who are more susceptible to side effects. Most commonly, NSAIDs affect gastrointestinal tract, affect heart, cause nephrotoxicity, and increase risk of bleeding. But how's that gonna happen? Well, to learn that, let's dive into it. If we talk about gastrointestinal tract first, in the stomachox, one produces prostaglandins, PGE2 and PGI2, that stimulate mucus, and bicarbonate secretion also cause vasodilation. All of these being the actions that protect the gastric mucosa, while non-selective NSAIDs mostly inhibit COX-1. So they reduce the cytoprotective effects of prostaglandins and frequently cause serious upper gastrointestinal side effects, including bleeding and ulceration. Now, proton pump inhibitors are widely used to avoid upper gastrointestinal toxicity, as they inhibit the proton pump present in the stomach, but this obviously does not prevent blood loss from the lower GIT as in the small bowel, which is a significant cause of anemia in patients on non-selective NSAIDs. Also, misoprostol, which is a PGE1 derivative and is effective in preventing the gastrointestinal toxicity of NSAIDs. It is mainly indicated in patients with a history of peptic ulcer whose need for NSAID treatment is such that the analgesic cannot be withdrawn. Whereas the newer selective COX-2 NSAIDs, one of them being celecoxib, are associated with a much lower incidence of gastrointestinal toxicity. Now, what are the negative consequences of NSAIDs on our heart? Well, agents such as aspirin, with a very high degree of COX-1 selectivity, are thought to reduce the production of thromboxane A2, which is responsible for vasoconstriction and platelet aggregation as well. So this decrease in thromboxane A2 will lead to the cardiovascular protective effect. Now, agents with higher relative COX-2 selectivity possibly decrease prostacyclin, or we can say prostaglandin I2 production, mediated by COX-2 enzyme. So the prostacyclin-mediated vasodilation is inhibited and therefore has been associated with an increased risk for cardiovascular events like MI and stroke. This effect has been associated with all NSAIDs except aspirin. Use of NSAIDs other than aspirin is discouraged in patients with established cardiovascular disease. However, other than that, naproxen appears to be the least likely to be harmful. So, in such patients, naproxen can be used, but use should be limited to the lowest dose possible for the shortest duration. One thing worth noticing here was that thromboxane A2 and prostacyclin have opposite effects. Thromboxane A2 is a vasoconstrictor, while prostacyclin is a vasodilator. And that is the reason why inhibition of their production by NSAIDs will have opposite effects. Now, if we talk about kidney, NSAIDs are associated with nephrotoxicity. Well, prostaglandin E2 and prostaglandin I2 both are powerful vasodilators. PGE2 being synthesized in the renal medulla, while prostaglandin I2 is synthesized in glomeruli. Both of them are involved in the control of renal blood flow and excretion of salt and water. Now, when renal prostaglandin synthesis is inhibited by NSAIDs, salts are not excreted, and that may result in sodium retention, reduced renal blood flow, and renal failure, especially in patients with conditions associated with vasoconstrictor, catecholamines, and angiotensin II release, for example, congestive heart failure, cirrhosis. In addition, NSAIDs may cause hyperkalemia or an increase in potassium level and interstitial nephritis, which is a kidney disorder in which the spaces between the kidney tubules become swollen. Moreover, prolonged analgesic abuse over a period of years is associated with chronic renal failure and papillary necrosis, which is kidney damage characterized by coagulative necrosis of the renal medullary pyramids and papillae. Next comes the increased risk of bleeding associated with NSAIDs. You all are well aware of the fact that NSAIDs increase the risk of bleeding. But how is the question? Because we previously discussed about the antiplatelet activity of NSAIDs. Let's recall that for a better understanding. Thromboxane A2 promotes the platelet aggregation process that is essential for the rapid formation of a hemostatic plug, whereas prostacyclin, working in opposite, decreases it. Aspirin now irreversibly inhibits COX-1-mediated thromboxane A2 formation, while other NSAIDs reversibly inhibit the production of thromboxane A2. Because of the decrease in thromboxane A2 production, platelet aggregation, which is the first step in thrombus formation, is reduced, producing an antiplatelet effect with a prolonged bleeding time. Because platelets lack nuclei, they cannot synthesize new enzyme when inhibited by aspirin, and the lack of thromboxane persists for the lifetime of the platelet, which is about 3 to 7 days. For this reason, aspirin is often held, or not given, at least 1 week prior to surgery. Though NSAIDs other than aspirin are not utilized for their antiplatelet effect, but can still prolong the bleeding time. As agents become more COX-2 selective, they are expected to have less effect on platelet inhibition and bleeding time. One thing more I would like to mention here is that patients who take aspirin for cardioprotection should avoid concomitant NSAID use if possible, because NSAIDs can also block aspirin binding to cyclooxygenase when used concomitantly. Other than this, NSAIDs are inhibitors of cyclooxygenases, and therefore inhibit the synthesis of prostaglandins, but not of leukotrienes. Inhibition of prostaglandin synthesis can cause a shift toward leukotriene production, and therefore increase the risk of exacerbations of asthma. For this reason, NSAIDs should be used with caution in patients with asthma. Few other adverse effects associated with NSAIDs are related to central nervous system, CNS, such as headache, tinnitus, and dizziness. In addition to CNS-related effects, approximately 15% of patients taking aspirin experience hypersensitivity reactions. Though fatal anaphylactic shock is rare, but still, patients with severe hypersensitivity to aspirin should avoid using NSAIDs. So that was a quick overview to NSAIDs. Hope it was engaging for you. To watch more upcoming videos, stay tuned to sqadia.com.